Hey, good morning and welcome to Euronurse. Sorry about the late start. Nothing I could do. Been using StreamYard for over a year. Never had a problem with it not starting, but I pushed the button, kept getting warnings. We're experiencing issues. They were, I guess. But hey, we're here now, so let's go on with our show. If you're watching us on any of our channels that are going out simultaneously, welcome to the show. Be sure to hit the subscribe and like button. Not getting our email, go ahead and subscribe to our weekly email through MailChimp. That's on our website. Speaking of our website, be sure to visit euronurse.com to learn more about the show, the best place to go to get information on the show. Also, the best place to watch our past episodes. We have 97 of those episodes available to watch. And if you like listening in your car and don't want to watch the show, no problemo. Go to our Euronurse Plus area. We have an audio podcast that comes out after every show with just the audio. So it's a great place to listen. Also, keeping this date in mind, June 29th, only a couple weeks away, our 100th episode. It's going to be all sorts of great stuff going. We're giving away some $10 gift cards from Euronurse. We've got our experts coming on. We've got some of our sponsors are going to be joining us for the show. And you guys can even join the show if you want. You can send a quick video. I'll put some of those together. If you don't want to be on the show video wise, just send a quick clip with your information. You know, hey, I like the show. Put it in our Ask Euronurse area and we'll include you in the show. So we're looking forward to that show coming up in a couple of weeks. Now, this week, we are proud to have Dr. Berger joining us. Dr. Berger works in my organization, so I know him well. He's going to be talking about advanced prostate cancer. Let's go ahead and bring in our experts right now. Experts, welcome to the show. Hey, how's everybody doing today?
Good morning.
Good.
Sorry about that late start, but we're finally here and going. We're going to do our intros and we'll make them quick just to get through it. But hey, I got a great thing I wanted to share with everybody. If you notice, I got a few more initials and so does Andrea. So this came in the mail yesterday. Both Andrea and I are now fellows of the Academy of Urologic Nurses and Associates for our great contributions to urology in SUNA. So, hey, congratulations.
Well deserved.
Yep. So now we got more.
Your official fauna. Is there a flora? Is there a flora somewhere too, or just fauna?
So far, that's the next organization I'll have to join.
Yeah, you got to start a flora as well.
There you go. All right, Andrea, go ahead and give your introduction.
My name's Andrea Strong. I'm a nurse practitioner in Wisconsin. I've been working in urology for a long time. I've done everything from a nursing assistant, nurse practitioner, and everything in between. So I'm really looking forward to Dr. Berger's presentation today.
All right. And Dr. Berger, give your introduction and then we'll bring up your slides.
Good morning. So Aaron Berger, I'm a urologist at Associated Urologic Specialists in the south part of Chicago, which is Vic's stomping ground as well. So I've known Vic for since I started practice almost 16 years ago. So yeah, thanks for the invitation. Happy to be here. And sorry, my lighting is a little bit dim. I'm not in my normal home studio. I'm out of town for the weekend. So hopefully it doesn't accentuate my wrinkles too much. So.
All right, let me go ahead and switch you over to the viewing. So you have to just move those into full stream.
Yep.
Or full.
All right, good. You can see.
Yep, but we're not full screen yet. You have to hit that little.
Yep, screen. It's full screen. It's full screen on my end.
So we're getting the presenter's view right now with all the slides on the side.
Let me try again. It's full screen on my end here, so let me try one more time. All sorts of...
Sometimes you have to share the window.
Okay, share screen. All right, how's that? Better?
So I've got the screen, but it's not the full screen.
It's full screen on my end. We're in presenter mode.
Try clicking slideshow at the top middle.
Yep, it's there. Since we're doing slideshow.
Protected view.
Hold on, let me try.
That's just enables editing.
I wonder if you try view, it gives you a different option.
It's full screen on my side, Vic.
Yeah. Let me see if there's some way I can make it bigger.
My whole screen is.
I'm going to try to stretch it out on my side, see if I can make it large enough to. I think we'll go with that. It's just going to have the little slides on the side, but at least we've got the best view I've got right now.
Okay. Yeah. Sorry. It's on present mode as far as I can see on my screen.
Yeah.
So.
All right.
All right.
I made them bigger.
I'm sorry.
I made the slides as big as I can on my side. So.
Okay. All right. So again, thanks for the invitation. We're going to be talking about Xtandi or enzalutamide, which I'm sure many of you are familiar with. If you do anything with prostate cancer, it's been around for several years now, but we're going to be highlighting one of the newer indications. So treatment intensification with Xtandi for patients with metastatic castration-sensitive prostate cancer, as well as non-metastatic castration-sensitive prostate cancer with biochemical recurrence at high risk for metastasis. So I heard about me already. This is a promotional Astellas and Pfizer program, so they do compensate me for this. There's no CME, just educational purposes today. So Xtandi is now indicated pretty much across the spectrum for any advanced state of prostate cancer with castration-resistant prostate cancer, metastatic castration-sensitive prostate cancer, as well as non-metastatic castration-sensitive prostate cancer or NMCSPC with biochemical recurrence at high risk for metastasis. So that's a mouthful. We need to come up with a better acronym for that, but that's what the FDA came up with for this new indication. And we'll go through what that actually means. So we're going to be talking about understanding the position of Xtandi in the treatment landscape for prostate cancer, defining prostate cancer, which is the indication that came out a few years ago. So as I mentioned, there's several disease states in the prostate cancer continuum that Xtandi is now approved for. So this new indication here, this is the non-metastatic clinically localized disease or non-metastatic CSPC with high-risk BCR.
You know what, Aaron, we're looking at the first slide still.
Well,
now it changed.
It's moving through in my side here, Vic, so I'm not sure what else. Should I try to log out and come back in and see if that helps?
I think what we need, let's try your presentation mode again. So we'll kick your slides out, remove those. I'm gonna.
Okay. So I'll stop sharing and then try to restart.
So stop sharing. I think we just have to share a different way.
Do you want me to just email you the slides real quick? Would that be better?
Well,
let me stop sharing and try to restart.
Are they PowerPoint? Are they PowerPoint?
Yeah.
So go to present.
Yep.
Slides. And then
add from your computer.
Your computer, and you can upload it from there. It'll upload it to the show.
Okay.
Sorry, folks, for the delay. I guess
it was working fine when we tried it the other day.
I know.
Maybe their server is the problem here.
It could be.
All right, it's going.
It's going, yeah. So sometimes it's going to spin for a little while, then it'll show up.
Yeah, it's coming. It's almost there. Okay, processing. Okay.
There we go. I see him.
Okay, so now I'll just click through it here. All right. All right, so this we talked about already. Here's, so this is the different indications currently. This is working okay, Vic?
Yep, perfect.
Okay. All right, so this is all the different indications we have currently for Xtandi. So there's recurrent metastatic castration-sensitive disease, de novo metastatic castration-sensitive disease, as well as metastatic castration-resistant prostate cancer are all covered by Xtandi. So Xtandi kind of at this point runs the gamut for pretty much any state of advanced prostate cancer. We're going to talk about two of the indications in a little more detail in the presentation today. So Xtandi has been widely utilized, so it's been approved in the U.S. and for various indications since 2012. There's been over 300,000 patients just in the U.S. alone since FDA approval back in 2012. So widely studied, lots of real-world data. But there are, as with any medication, as I always tell patients, if you watch TV and see ads for medications, half the ad is about what can happen. So this is the potential concerns with Xtandi. So seizures. So seizure occurred in about 0.6% of patients receiving Xtandi. If there's predisposing factors, it was about a little over 2%. And certainly if any patient who has no history of seizure develops a seizure during treatment with Xtandi, they should stop treatment. And if they have a history of seizure or any neurologic disease that can cause seizure, they should not be taking Xtandi in the first place. PRES, we'll talk about a little later. This is a neurologic constellation of symptoms that has been reported. It was not seen in the trials, but has been reported since it came to market. Hypersensitivity, of course, any medication people can have a reaction to or allergy to. You really don't know until you try it. It's pretty rare with Xtandi, but if it happens, certainly should stop it. Ischemic heart disease, you want to optimize management of cardiovascular risk factors and discontinue Xtandi for any more significant cardiovascular toxicity. Falls and fractures were a little bit higher in the trials. We'll talk about that in a little more detail as well. And embryo-fetal toxicity, so Xtandi can cause fetal harm and loss of pregnancy. So if patients, we don't think about this too much, as most of the time this is an older patient population. But if you do have younger patients who but have partners who still could be of reproductive age, they definitely need to use contraception, or if they are trying to conceive, they need to have a washout period before they move forward with trying to conceive a child if they've been taking Xtandi. So this non-metastatic CSPC with high-risk BCR. So again, this is patients who have had clinically localized prostate cancer. They've had definitive therapy such as radiation, surgery, cryoablation, whatever type of local surgery, and then they develop a biochemical recurrence. So those patients then can be defined as kind of low risk or high risk, depending on their other clinical parameters. So the Xtandi is now indicated for this BCR with high risk for metastasis, and they do not have any signs of metastatic disease on imaging. So non-metastatic with high risk for metastasis is the new indication for Xtandi that came out last year, and this is in the guidelines as well. So for patients after prostatectomy, the definition of recurrence would be if the PSA is initially undetectable and then goes above 0.1 and it is confirmed with another increase if it was previously undetectable. And the AUA, or American Urologic Association, defines it as 0.2 and higher. So slightly different, but basically 0.1 or higher and confirmed, or 0.2 or higher and confirmed, depending on which organization. But either way, those are both biochemical recurrence. And after radiation treatment, and this is important because sometimes this gets confusing, but if they've had radiation, it needs to be greater than 2 nanograms per milliliter of their PSA higher than their nadir. So if they get to a PSA of 1 after radiation, we would not consider them recurrent unless their PSA is 3 or higher. So I just want to make sure we're doing this appropriately for the correct patient population. So what makes them high risk? So high risk factors would be the pathological tumor stage. So if they had grade 3 or stage 3 disease on their pathology, meaning any extracapsular extension, seminal vesicle invasion, things of that nature, higher Gleason score of 8 or higher, and how long it takes for the biochemical recurrence to occur. So if they've had surgery or radiation, 10 years ago and their PSA starts rising, that may not qualify as high risk. Whereas if it's 6 months or a year after treatment, that certainly would be more concerning. And the other factor we look at is the PSA doubling time, which is the time, just like it sounds like, for PSA to double. So in the studies, if it's 9 months or less, that definitely is a higher risk of metastasis and cancer-related death. So the real-world evidence here, looking at PSA doubling time, so this just shows the survival curves, the Kaplan-Meier curves here, you can see that if the doubling time is less than 3 months, patients do very poorly. If it's 3 to 9 months, again, there's still increased risk of metastasis and death. And once you get out past 9 months and a slower doubling time, they certainly do better overall. And other factors associated with progression can be that higher Gleason score, like we talked about, the initial pathology, and other high-risk features. So this study is limited. It's a retrospective study, so you can, take some of it with a grain of salt, but certainly it stands to reason that if a PSA doubling time is shorter, patients are progressing faster and are going to have an overall poorer prognosis. So how do we monitor patients after therapy? So the NCCN recommends PSA testing every 6 to 12 months for 5 years, and then annually after year 5. The AUA says PSA testing again 3 to 6 months for the first couple years, and then every 6 months between year 2 and 5, and then annually after year 5. In high-risk patients, you can do it sometimes a little bit more often. Every 3 months may be necessary to clarify disease status. So we'll do a quick case study here. So this is Richard. He's an engineer. He's married with 2 children. He's 62 years old. He's been having prostate cancer for the last 3 years. He had Gleason 8 disease, a PSA of 5, and no signs of metastasis. He underwent definitive therapy with prostatectomy, and PSA initially went down to 0.1. After a period of time, however, his PSA starts increasing and goes to 0.6, which prompts him to get salvage radiation therapy plus a short course of hormone therapy. He goes back down to an undetectable PSA, and then his PSA starts rising again relatively quickly. And his PSA doubling time is about 5.3, but he does have imaging with a PSMA PET scan, and there's no signs of metastasis. So certainly given his clinical features with the Gleason 8, the rapid doubling time, he certainly would qualify as high-risk biochemical recurrence, and he has no signs of metastasis on his PET scan. So he would qualify for this new indication of non-metastatic castration-sensitive disease with high-risk BCR. And again, castration-sensitive just means that they have not yet started hormone therapy or androgen deprivation therapy, or they are still responding to it, is what CSPC means. So basically, his treatment options would be just to monitor him, put him on hormone therapy, and then check his labs periodically. That would be certainly that this is the kind of options we've had in the past, is just kind of wait it out or just put him on hormone therapy alone. But with the new indication for this non-metastatic CSPC with BCR at high risk for metastasis, which was done via the trial called EMBARK, which was presented at the American Urologic Association meeting last year around this time in 2023. And then the indication came shortly thereafter. So we'll run through that data here quickly. So the EMBARK trial basically included patients who previously had radical prostatectomy or radiation therapy, either external or brachytherapy. Their screening PSA was greater than 1 after prostatectomy, or at least 2 points above the nadir after radiation, and the doubling time was 9 months or less, and they had non-metastatic disease. If they had previous signs of metastasis, they were not included. If they had had prior hormonal therapy, they were not included. If they had a prostatectomy and they were a suitable candidate for salvage radiation per the investigator guidelines, then they were sent for salvage radiation rather than putting on the trial. If they had previous chemotherapy, they were excluded. Again, previous seizure, they were excluded. And clinically significant cardiovascular disease patients were also excluded. So this is a multinational randomized phase 3 trial in about a little over 1,000 men with this non-metastatic hormone-sensitive prostate cancer with high-risk BCR. And they stratified patients depending on their PSA of 10 or higher or lower, doubling time of less than 3 months versus greater than 3 months to 9 months, and any prior hormonal therapy. And they were randomized in this stratification here. And the interesting thing here is previously with all the other indications with Xtandi, it was always with this combination. So Xtandi plus hormone therapy, GnRH therapy, ADT, whatever you want to call it. They also had placebo plus ADT. And the interesting part of this study was they also were given, there was an arm of the trial that was given Xtandi by itself, or Xtandi monotherapy, which is the first time that's been studied for Xtandi or really any of the other similar agents in this space. The other interesting part of this trial is if they were able to get to an undetectable PSA, which was defined here as 0.2 or less, patients were then stopped on treatment, or basically given kind of a treatment holiday at week 37. And then their PSA was monitored thereafter. And if it started to rise, they restarted on therapy. If they never did get to a PSA below 0.2, then they just stayed on treatment. And the primary endpoint here was metastasis-free survival. And the secondary endpoints were time to PSA progression and the time to the first use of other therapies and overall survival. So this is just the demographics. So very balanced cohorts between the groups, as we have in most of these trials. But you can see here the doubling time of less than 3 months was about roughly about 20%. So those are patients that are really rising rapidly. So as far as the primary endpoint, so this did reach its primary goal of showing that there was a 58% reduction in the risk of metastatic progression or death with Xtandi plus hormone therapy versus the placebo plus hormone therapy. So it did reach clinical significance with its with the combination of Xtandi plus hormone therapy versus the placebo plus hormone therapy. Overall survival data, not yet mature enough to determine overall survival, but as I said, the primary endpoint here was metastasis-free survival, and it did achieve that with nearly a 60% reduction in metastasis-free survival. And again, as far as the Xtandi by itself group, that also did achieve its primary endpoint with a 37% statistically significant reduction in the risk of metastatic progression or death. So both in combination with hormone therapy, which has been the traditional use of Xtandi, as well as with Xtandi by itself versus the placebo and hormone therapy, the Xtandi groups were superior on both counts to the placebo group. And when patients, the patients who did get down to that undetectable level and were allowed to stop treatment, you can see here that there was about 91% in the combination therapy they were allowed to stop, about 68% in the placebo and hormone therapy, and about almost 86% in the Xtandi monotherapy reached that undetectable level of less than 0.2. And then the question, of course, becomes how long were they able to stay off of therapy? So if they were on the combination, they were able to stay off for on average 20 months. If they were on the hormone therapy by itself and a placebo, it was just under 17 months. And if they were on Xtandi by itself, their time off of therapy was about 11 months. So a little shorter time with Xtandi by itself, which we would expect because it does the effects certainly do wear off faster than patients who are getting ADT injections, which takes a little longer for the testosterone levels to start to increase. But still, patients were almost off therapy for almost an entire year. As far as the grade 3 or 4 more significant reactions during treatment, about 46% with the combination therapy, 43% with the hormone therapy by itself, and about 50% with the single agent therapy. And we'll go through, what some of those were. So as with any prostate cancer treatment involving hormone therapy or hormone manipulation, certainly hot flashes was a very common side effect. But you can see here the high grade problems is pretty minimal. It's pretty rare to have someone that has such severe hot flashes that they want to stop therapy. But certainly it is very common. Much better in the Xtandi monotherapy group, which is one of the benefits of using Xtandi as monotherapy because you really don't get the hot flashes nearly as much. Other potential side effects like hemorrhage, fatigue, cognitive disorders, musculoskeletal pain, diarrhea, nausea, all pretty similar across the groups. One area to point out here was the gynecomastia. So with Xtandi by itself, when you're not suppressing the testosterone production, the incidence of gynecomastia or breast enlargement definitely was higher, almost 50%. In the Xtandi single agent group versus in the combination or the ADT therapy alone group. The ischemic heart disease, pretty similar across the board. between the different subgroups. So as far as permanent treatment discontinuation, so 21% of patients stopped therapy with the combination, 10% with the ADT or GnRH alone, and 18% with Xtandi monotherapy. And most common adverse reactions that led to permanent discontinuation were fatigue, hot flashes, nausea, and some cognitive disturbances. Dose reduction, about 7% in the combination, 4.5% with the hormone therapy alone, and Xtandi single agent was about 16%. And fatigue was the most common frequent adverse reaction, and that's similar to other trials involving Xtandi, where fatigue was somewhat the cause of dose reduction for most of those patients. So a little more detail on the seizures. So again, we talked about seizure a little higher in the trial. So if patients have a history of seizure or any neurologic disease that could cause seizure, they really should not be taking Xtandi. It's unknown if anti-epileptic medications will prevent seizures with Xtandi, which is why we just don't want people who have a history of seizure to even be taking it. And certainly, as with any new medication, I always tell people, take it in the evening when you're not going out. We don't want you driving or, doing other stuff, operating machinery, things like that. When you take your first dose of a new medication, just make sure you are in a situation where it's not going to cause any harm to yourself or others when you're taking something for the first time. And certainly if someone develops a seizure on treatment, they should permanently discontinue. So PRES is this constellation of neurologic symptoms such as seizure, headache, lethargy, confusion, visual disturbances that happens. Again, it was not seen in the trials. It was only seen after Xtandi came out in some post-marketing analyses. But basically, if this is something that needs to be confirmed with MRI, and certainly if it is confirmed, they should permanently discontinue Xtandi if this does happen. So biochemical recurrence is a sign of progression in these patients. So Xtandi is a treatment option for patients who are diagnosed with metastatic CSBC. So we're kind of, as well as now we're moving kind of the metastatic space. So this is a little transition here to one of the previous indications for Xtandi, which is for metastatic hormone-sensitive prostate cancer. And that can be either recurrent or de novo, and we'll get into what that means. So patients with de novo metastatic castration-sensitive disease have poor survival chances compared to patients who have localized cancer. So that means that they walk in the door and you diagnose them with metastatic disease from the get-go. In the SEER database, which is a large Medicare database, 5-year survival was evaluated and was about 100% with patients with localized prostate cancer, only 34% with de novo. Certainly this is between 2013, 2019. We have a lot of new treatments for advanced prostate cancer. So, likely more contemporary data may show that this is a little better, but certainly when you have someone with metastatic disease, when they walk in the door, is going to have a more challenging prognosis than if they have localized disease at the beginning. So patients can get treatment intensification if you have metastatic hormone-sensitive disease. This is from the 2023 NCCN guidelines. So they can get an androgen synthesis inhibitor plus hormone therapy, an androgen receptor inhibitor plus GnRH therapy, chemotherapy plus hormone therapy, as well as a certain androgen receptor inhibitor. And then the older medications that we had been using previous to the last several years, first generation anti-androgens such as bicalutamide or flutamide, that is not typically recommended as highly. So that's really not standard of care in 2024. So, at least in our practice, we try to keep those to an absolute minimum unless there's some extenuating circumstance where the patient just can't take anything else. So once you start them on treatment, they should be monitored every 3 to 6 months with exams, PSA testing, as well as testosterone testing if they're on GnRH therapy, as well as imaging. So this is the ARCHES trial. So this is a little few years ago, but this is the trial that was for metastatic hormone-sensitive disease. This is now in the guidelines. Both NCCN and AUA has this as Category 1 or Grade A evidence that this should be considered for patients with metastatic castration-sensitive prostate cancer. So the ARCHES trial basically had patients with confirmed prostate cancer and metastatic cancer documented on bone scan or CT or MRI. So this is conventional imaging, not PET scans. The PET scans were not as widely used when the study was done, and a good performance status. And this could either be de novo, meaning they have metastasis at diagnosis, or it could be what's called recurrent MCSPC, which means that they had radiation, they had surgery, and then in their follow-up, they were found to have metastatic disease and progression with metastasis. So if they had previously had any other surgery or other agents, they were prior to randomization, they were excluded. Again, any history of seizure or neurologic disease that can cause seizure, any history of TIAs or loss of consciousness, and if they had significant cardiovascular disease, such as recent MI, recent exacerbation of CHF, things like that, they were also excluded. So about 1,150 men here were enrolled, randomized 1-to-1 to get Xtandi plus GnRH therapy or hormone therapy versus placebo. Again, here primary endpoint was radiographic progression-free survival. Secondary endpoints was PSA progression, time to starting new therapy, getting the PSA down to an undetectable level, time to any change in urinary symptoms, as well as what we consider one of the more important things here is overall survival. And they were also stratified based on volume of disease and patients who previously had chemotherapy. So basically, volume of disease, low versus high, and if they had had previous chemotherapy before they enrolled, they were allowed to have less than 3 months of hormone therapy before enrolling if they had not gotten chemo, or less than 6 months if they had gotten chemo. And they were allowed to have 1 course of palliative radiation to a symptomatic bone lesion. And again, they were allowed to have 6 cycles or less of chemotherapy prior to enrolling. So this included patients with both low and high volume disease, as well as about 20% of almost 20% of patients had previously received chemotherapy in this trial. So here's just the baseline demographics. Again, very balanced cohorts, as we would expect in these trials. But you can see almost 2/3 of patients had what we consider high volume disease. So this is a pretty substantial high volume prostate cancer population. So the take home message here in the ARCHES trial was it did reach its primary endpoint with a 61% reduction in the risk of radiographic progression or death with the Xtandi group versus the placebo group. So significant was achieved there with the primary endpoint. And it also, when they did further analysis and did the final analysis, as important, if not more so, especially for patients to understand, was overall survival with a 34% reduction in the risk of death with Xtandi versus the placebo group. So, I think it's much easier to explain overall survival, just telling patients they'll live longer with the treatment versus radiographic progression-free survival, which is a little bit more esoteric for them, but certainly it did achieve these primary endpoints, as well as the key secondary endpoint here of overall survival, showing Xtandi was superior to hormone therapy alone. Again, safety profile, similar to what we talked about in the EMBARK trial, hot flashes, hypertension, some fractures, appetite issues, cognitive disorders, all very low rates of grade 3 to 4 toxicities, but the fatigue, a little bit higher in the Xtandi group versus the placebo. Grade 3 or 4 adverse reactions were actually a little higher in the placebo group. And the discontinuation rates were very similar, about 4.9% with Xtandi and 3.7% in the placebo group. So some additional safety information. This goes, this is Xtandi in general. This is not specifically to any one trial. So hypersensitivity, again, pretty uncommon. You really have no way to predict this until they try it. But some patients do get some hypersensitivity with some swelling or of the lips or tongue or face. It has been observed, obviously, if this happens, they should stop taking it. Ischemic heart disease, the rates of ischemic heart disease or cardiovascular issues are a little bit higher in Xtandi-treated groups across the different placebo-controlled studies, and there have been multiple of them for Xtandi now over the last 10, 12 years. So certainly you want to make sure patients are as optimized as they can be. Now, obviously, a lot of patients have cardiovascular disease, and you want to make sure you're also treating their significant prostate cancer. So you want to work with your primary care doctor, work with their cardiologist to try to optimize them as best as you can. But if they do have any significant high-grade side effects related to ischemic heart disease, then you want to discontinue taking Xtandi. Falls and fractures, those were a little bit higher in the studies as well, with about 12% of patients in Xtandi groups versus 6% in placebo. and fractures were also a little bit higher. Now, typically these were not associated with loss of consciousness, but they were a little bit higher reported. So if you have patients who have, significant difficulty walking or gait disturbances or can barely stand up, again, you just want to be very cautious when you're starting these medications. And we kind of touched on the embryo-fetal toxicity earlier. So they need a 3-month washout period after they've been on Xtandi if they do want to try to conceive. Again, here's the most common reactions: the musculoskeletal pain, fatigue, hot flashes, constipation, appetite issues, hypertension, hemorrhage, fall, fracture, and headache. These were, again, in all the trials for Xtandi, these were a little bit higher than in placebo, but discontinuation rates were relatively low, 16% in the AFFIRM trial and 6% in the PREVAIL trial. This is some of the older trials, but similar to most of the other Xtandi trials, that the side effects are all pretty similar, which we'd expect since it's all the same medication. Hypertension, and the combined data from the 5 randomized trials, hypertension was a little higher in the Xtandi group versus the placebo, led to study discontinuation, however, in less than 1%. Typically, if we do have some issues with hypertension, we'll try to work with the cardiologist or primary care doctor and just get that controlled a little different way, especially if they're responding well to Xtandi for prostate cancer. We prefer to try to keep them on that, as there are multiple options to control high blood pressure, where we may not have as many good options for prostate cancer treatment. And lab abnormalities that occurred in greater than 5% were some changes in decrease in hemoglobin, decreased neutrophils, decreased white blood cells, some hyperglycemia, hypermagnesemia, natremia, hypophosphatemia, hypercalcemia. But there is not any significant issues with the labs that you're required to check any basic metabolic panels or comprehensive metabolic panels to check liver function or electrolytes on a regular basis with Xtandi. It's really just checking the PSA and testosterone levels as we would normally do with these patients. So as far as dosing administration, Xtandi now comes in a few different options. So there's the 40 milligram capsules, which was the original form. There's also the 40 milligram tablets, which are a little bit smaller. And then the 80 milligram tablets, you take 2 of those a day. So the total dose is 160 milligrams. Most of my patients, I've now switched to the 2 a day. Most people would like to take 2 a day rather than 4 a day, but sometimes they are slightly larger. So if there's any swallowing issues, they can do the 4 tablets, which are a little bit smaller. They should also continue to be taking the ADT along with it, unless they are in that category of the EMBARK where you're going to do Xtandi monotherapy. But certainly with all the other indications for Xtandi, you do need to continue with hormone therapy. Dose adjustments from mild to severe hepatic or mild to moderate renal impairment is not necessary initially. So if their creatinine clearance is really poor, or if they have like end-stage renal disease, Xtandi has not really been evaluated. It doesn't mean you can't potentially use it, but you do just need to be cautious initially. And there's no significant differences in the pharmacokinetics based on age, body weight, or mild to moderate renal or hepatic impairment. But certainly, with the dosing, you can, make some adjustments as needed. And remove 1 capsule and do a 25% reduction or 50% reduction in dosing, depending on what's going on with the patient, and see how that works. So Xtandi is taken once a day. So either with or without food, it doesn't matter. Around the same time every day. I tell people they don't have to set like an alarm clock and take it at 5:07 on the dot every single day, but around the same time every day. If they forget to take a dose, they should not like double up the next day. They should just say, you know what, we missed it, and just restart taking the regular dose the same day or the next day. And they should be swallowed whole. These capsules or tablets should not be crushed up or blended or Vitamixed or any of that kind of stuff. They do need to be swallowed. So if patients do have swallowing issues or can't swallow pills or tablets, this unfortunately is not going to be an option for them. So as far as other drugs, these DDIs or drug-drug interactions, most of us these days have pharmacy software. So normally when you order medications, assuming that the patients have their rest of their medication list in your systems properly, it should give you some sort of alert that there could be a problem, but you can always rely on the Pfizer or Astellas medical science folks, or talk to your reps. If you do have any specific questions, they can get that information for you. Sometimes there's not a great answer. They may say it's just not been studied. We don't know, but it is metabolized in the liver. So the cytochrome system There can, if there's drugs that are involved in the similar pathways, you may try to avoid that if you can. But again, these days, so many patients are on so many different medications that, if they have metastatic or high risk prostate cancer and you want to get their cancer under control, you do your best to try to work with the pharmacy software, the pharmacist, medical science people to really make sure there's no significant interactions. But otherwise, we normally will just give it a try and make sure there's no issues moving forward. As far as access, this Xtandi, just like all these cancer medications, are not inexpensive, but the Xtandi, it does have a lot of support to try to get patients coverage. So depending on their benefits, you can use specialty pharmacy or Xtandi support solutions. There's a patient savings program, there's the patient assistance program, and there's financial assistance available for Medicare patients and patients who have no insurance. They do have the patient assistance program, which sometimes can get the medication for them depending on income levels, free of charge, which is great. So in summary, Xtandi can be used earlier in select hormone-sensitive prostate cancer patients, or CSPC patients, as the first and only androgen receptor inhibitor approved by the FDA in 4 advanced prostate cancer disease states. So you have non-metastatic CSPC with biochemical recurrence who are at high risk for metastasis, and we talked about what that means. Metastatic castration-sensitive prostate cancer, we also talked about that in the Embark and Arches trial. And then there's the other 2 indications that Xtandi can be used for, which is non-metastatic castration-resistant prostate cancer or metastatic castration-resistant prostate cancer. So Xtandi really can be used for almost everything these days except just localized disease. And again, seizure, PRES, hypersensitivity, ischemic heart disease, falls, fractures, and embryo-fetal toxicity are the warnings you should be aware of. So with that, sorry for some of the technical glitches, but I think we got through it. So happy to take any questions if there are any.
Yeah, that was really great. I did just throw this on the screen from the company. This is a website you can go to for more prescribing information. Again, if you have any questions, please put those into the comments section. Otherwise, we're going to turn it over to our experts to start asking questions. Our 2 experts that we have on. I'm going to kick it off. So, where do you see this being used as far as early prostate cancer, non-metastatic? I mean, how aggressive are you getting with treatment?
Well, I mean, certainly there's a lot of factors that go into an individual case, but certainly with the new indication, we certainly are much more fine-tuned as far as looking for these patients. I think those of us that have a data analytics program or trying to monitor prostate cancer patients with navigation, which is certainly very important for having a good prostate cancer program, is having navigation and really following these patients and identifying those who are eligible for therapy. We've really changed our filters and settings to try to identify these patients much earlier. And then I think the real question comes in is, if a patient is having a recurrence and their PSA doubling time is relatively fast, and they have some high-risk features, do we potentially discuss with them just going on to Xtandi plus either Xtandi by itself or Xtandi combination therapy without necessarily moving forward with getting next generation imaging like PET scans, potentially just using conventional imaging, which is how the studies have all been done with Xtandi to date, and just trying to use Xtandi in that setting with the Embark data. Or do we, at a relatively low PSA, do we get them a next generation scan like a PSMA PET scan and see if they have metastasis, and then potentially use Xtandi in the Arches setting? So really, either way, you can use Xtandi. The difference is the Xtandi monotherapy option, where you only use that by itself, would not be indicated if they have metastasis. So it's really something that we discuss with patients and say, these are the potential side effects if you do combination. These are the potential side effects if you do monotherapy. And if they're interested at all in monotherapy, then we probably would just do conventional imaging, which is how the studies were done. If they say no, I don't really want to do that, I'd rather potentially have the little longer time off treatment or whatever, the other benefits of doing combination therapy, then we may do a scan, because if they do have metastasis, then they would be on the metastatic, protocol, which is Xtandi plus hormone therapy anyways. And then the only difference there is we would typically not give them we would not stop therapy at 37 weeks. So, it's all, obviously patients can stop therapy whenever they want for any reason. It's always up to the patient if they want to continue or not. But, we wouldn't be kind of targeting that 37 weeks with undetectable PSA and say, okay, you've reached this point. In the studies, people stop therapy now. Do you want to stop? Do you want to continue? They always have the option to continue as well as stop. So it's kind of a fine line here, this with these two indications that we talked about today. But I think the bottom line is, Xtandi, like we said a few times, is really now available for almost, the full spectrum of advanced prostate cancer. So, it can really kind of be a go-to for almost any situation.
Thank you. Andrew, do you have any questions before I hog the screen?
For the sake of time, I'll skip the questions, but I just want to thank you for that excellent presentation. We do have a comment from one of the viewers here. Diane said, great information, and she wanted to thank you.
Thank you.
Yeah. All right, though, I'm going to hog the screen then. So I always liked, the presentation was great and a lot of information, but I like to dig into the real world. So what are you seeing with patients taking Xtandi as far as side effects? What's the most common complaint that you hear?
I think what we see and what the data would share or show us as well is just some fatigue. I think that it is a real thing. I think parsing out, is it from the hormone therapy? Because certainly hormone therapy, low testosterone in general will cause patients to have less energy and to have some fatigue at baseline. But, sometimes adding the Xtandi at the full dose, they just definitely do just have a lack of energy. And, sometimes just, the family will come in and say, oh, he doesn't want to get out of bed. He doesn't want to do anything, sits around the house all day. So that's a real thing. And I definitely have noticed a significant difference on a lot of my patients, even with a slight dose reduction. So if they're on the 4 pills, we'll just drop 1 and go to 3. And it's really amazing sometimes how much of a difference that can make in fatigue. And obviously if they're doing the 280 milligram pills, then you have to, we typically would then switch them to do 3 of the 40s so they can just go at 25% dose reduction. But that 1 pill sometimes, at least in my experience has really made a big difference in fatigue. Some of the other things we've seen is, some patients do have some joint discomfort, things like that. But I think in general, when you're going on balance as far as what it does for their prostate cancer versus the side effect profile, I think it's certainly very manageable. And to be honest, I haven't had a lot of patients. I think I've had 1 so far that's done the Xtandi monotherapy. He's been doing okay, but the gynecomastia there is definitely something that needs to be discussed with patients. And if patients do want to do that, there is, some data you can do like preventative radiation to the breast tissue, which can then prevent that from happening, but it needs to be done before you start. Because if, once it's there, if patients have significant breast enlargement, like doing radiation is not going to help. Then it's like really a plastic surgery issue if they want to get that taken care of. But, doing it in advance, can help, but that can also have some side effects just doing that as well. So that, is something it needs to be a combination discussion with the patient, yourself as the physician and the urologist or the oncologist, as well as the radiation oncologist to kind of figure out what makes the most sense.
Now, have you had patients that have gone off therapy and done well, after the 37 weeks of treatment? Yeah,
I mean, this came out, like I said, the indication, I think, changed. I don't remember the exact date, but the data was released in May of last year at the AUA, and I think the actual indication changed around October, November. Correct me if I'm wrong, any of them, the Astellas folks. But so we really are kind of just getting to the point now where we're getting close to that 37 weeks. So to be honest, I have not had anyone yet. I was not involved in this particular trial, so I don't have any of my patients. So I have a few patients who are on the medication combination and are at undetectable levels. So, we're just not quite enough time because we're, that's what, almost 9 months. We're just not quite there. But I certainly will give them the option because I think if they can, be off for 2 years or almost 2 years and have no issues as far as PSA progression, that's great. But, on the other hand, if they're tolerating therapy well, there's certainly plenty of data with Xtandi and ADT showing that if they want to continue longer, that the safety profile is really not changing significantly.
Mhm.
So, certainly a shared decision making we need to have with the patient. So there's nothing, none of this stuff is set in stone 100%, like it's cookie cutter for everybody. Everyone's different, and
Right.
everyone has different issues and financial issues and other medications. And if they take 20 other pills, they may say, oh, I want to take a break from this for a while. If they're doing good and their PSA 0 and they're happy, then they may just say, no, I don't want to rock the boat. So it really is something that needs to be discussed in detail and have shared decision making.
Yeah. That makes it more difficult than in the old days. You just kind of put people on it and just they were on it forever, and not a lot of patient thought and process. But as you say, the things have changed now that we can have these conversations with our patients and discuss these are some options you can try. And I mean, all these things have side effects. Any medication that you take, sometimes it's nice to have a holiday from it, especially
Oh,
if there's
absolutely,
data.
and especially with some of the new data coming out about long-term use of ADT or hormone therapy. There is some data showing increased cardiovascular risk, increased risk of some long-term cognitive issues. So if we can get patients off of ADT for any period of time, it certainly may have some benefits to them long term.
Wasn't there some like oversensitization that took place for people on ADTs a long time? I remember they used to take a holiday sometimes thinking that you could oversensitize cancer cells. I don't know if that's
Yeah, I mean,
something.
that's not, I wouldn't say it's necessarily the main concern at the moment. I think the main concern now is there's some data on it can potentially increase risk of dementia as well as cardiovascular toxicity. There is a paper out there about kind of alternating androgen deprivation and then doing high dose testosterone. It's called BAT, where you kind of go back and forth. It's like this bimodal thing, but that certainly is not, at least in the US, that's not standard of care. But there are some places that there is some data on that. It's a little bit counterintuitive, but that kind of goes to what you're saying about the androgen receptor and all that kind of stuff. But certainly not something that we're doing standard of care. But it is interesting. I mean, I think the more we learn about this, like anything else, then how we treat this now could be totally different in another 5-10 years, because it's totally different now than it was 5 or 10 years ago. So that's why I enjoy it and like doing it, because it's a very rapidly changing field with lots of new great options, and it keeps things interesting.
Yeah, it definitely. I mean, with all these choices, it makes it harder to, I think, stay on top of all this. That's why it's kind of nice having a program like this. I quite frankly didn't know that Xtandi was being used as monotherapy prior to this talk. So
There you go.
it's always good to learn more. So, and it's just like you say, so rapidly evolving, hard to keep up with it sometimes. So really appreciate you having you on the show. I'm going to give a little introduction a little promo for next week's show.
Enhanced Recovery After Surgery, ERAS. Protocols for prostate surgery emphasize a patient-centered approach to optimize outcomes and expedite recovery. Nurses are integral to this process, starting with preoperative education and preparation. According to Andrea Strong, it's crucial for nurses to ensure patients understand the ERAS pathway, which includes elements like carbohydrate loading, maintaining hydration, and abstaining from smoking. Through effective communication and patient education, nurses can empower patients to follow the ERAS guidelines, facilitating a smoother and faster recovery process and ultimately reducing the length of hospital stays. Join us next Saturday at yourownurse.com to learn more.
So our own Andrea Strong will be talking next week on that. So we're looking forward to that great discussion. And for those of you that are patients and you're watching the show, be sure to check out our europatient.com. Europatient podcast follows this show at 10:30. Hopefully no glitches on that program. In the meantime, I'd like to thank the speakers again. Thanks, Dr. Berger, for your great presentation, and Estelis for bringing this to us. And for the rest of you, see you next week.
All right. Thank you.